evaluation confirming the pattern. So once TMA is suspected, we need to establish the hemolytic pattern and simultaneously exclude important mimics. For hemolysis, we look for markedly elevated LDH, low or undetectable haptoglobin, and an increased reticulocyte count. To assess immune hemolysis, we perform the direct antiglobulin test. We also assess coagulation parameters PT, APTT, fibrinogen, and D-dimer, particularly because DIC can mimic TMA. And there is one particularly important practical point on this slide. Draw ADAM TS13 activity and inhibitor samples before administering plasma whenever possible. Once plasma has been given, interpretation of the ADAMS 13 result can become more difficult. Then we have the TMA triage matrix distinguishing the core entities. Now we need to distinguish the major TMA syndromes. In immune TTP, the defining abnormality is severe ADAM TS13 deficiency. In Shiga toxin associated HUS, the association is with Shiga toxin, typically with diarrhea and acute kidney injury. Complement mediated HUS is associated with alternative pathway dysregulation and often prominent renal involvement. And DIC is an important mimic, particularly when there is sepsis, bleeding, prolonged coagulation times, and low fibrinogen. Therefore, the diagnosis is not simply TMA. We need to ask which TMA is this and what mechanism is driving it, because the treatment pathways changes accordingly. The do not wait algorithm. So this is a practical algorithm I want everyone to take home. So start with a patient who has microangiopathic hemolytic anemia plus thrombocytopenia, raising suspicion for TMA. Immediately send baseline investigations and draw the ADAMS 13 sample. Then calculate the plasmic score and assess the overall clinical probability. And if the probability of immune TTP is high, do not wait for the ADAMS 13 result to return. Initiate treatment promptly. The key message is send the test, but don't wait for the test to treat a high probability TTP. Therapeutic pillar 1. So this is about plasma exchange and corticosteroids. The first therapeutic pillar shown here is plasma exchange together with corticosteroids. Plasma exchange has two important functions. First, it removes circulating pathogenic factors including autoantibodies. Second, it replaces functional ADAMS 13 through plasma. Corticosteroids are used to suppress the immune process responsible for autoantibody production. The slide highlights intensive plasma exchange and high-dose corticosteroid therapy as the initial therapeutic approach. So the principle is straightforward. Remove the pathogenic antibody, replace the deficient enzyme, and suppress the immune response. Therapeutic pillar 2, caplacizumab. The second therapeutic pillar is caplacizumab. The important difference here is speed. Plasma exchange addresses the underlying pathogenic environment, but it takes time to restore ADAMS 13 activity and stop the disease process. So caplacizumab, this acts directly on the von Willebrand factor platelet interaction. By targeting the A1 domain of von Willebrand factor, it rapidly blocks platelet adhesion and therefore interrupts ongoing microvascular thrombosis. So this explains its clinical value in acute immune TTP. So if I had to summarize this slide in one sentence, plasma exchange treats a cause, caplacizumab rapidly blocks the ongoing thrombotic process. Therapeutic pillar 3, long-term control. The third pillar is about controlling the disease beyond the immediate crisis. For immune TTP, rituximab targets CD20 positive B cells and it is used to reduce antibody production and prevent relapse. For complement mediated HUS, Complement inhibition with agents such as eculizumab or ravulizumab targets the terminal complement pathway. So once again, the key principle is mechanism based therapy. TTP requires control of the anti-Adams 13 immune response, whereas complement mediated HUS requires control of pathological complement activation. The therapeutic arsenal, aligning mechanism with timing. So this slide brings all the therapeutic options together and importantly compares them according to their speed of action and mechanism. Caplacizumab acts within hours to halt active thrombosis. Plasma exchange works rapidly by removing pathogenic antibodies and replacing Adams 13. Corticosteroids provide immunosuppression. Rituximab works more slowly over weeks to reduce the risk of relapse. And complement inhibitors target terminal complement activation in complement mediated HUS. So, treatment should not be thought of as choosing one drug, it is about matching the right mechanism to the right disease at the right time. Clinical pitfalls, fatal errors in acute management. There are three important pitfalls highlighted here. First, prophylactic platelet transfusion. So, severe thrombocytopenia in TTP does not automatically mean that platelets should be transfused. And second pitfall is normal coagulation test do not exclude TTP. So TTP is primarily a platelet von Willebrand factor microvascular thrombotic disorder. So PT and APTT may remain normal. Third, subtle neurological symptoms should not be dismissed. Headache, transient confusion, or other subtle neurological manifestations may represent cerebral microvascular ischemia. Therefore, we should avoid three dangerous assumptions. Low platelets do not automatically mean transfuse, normal coagulation does not exclude TTP, and subtle neurological symptoms do not mean mild disease. Case resolution, the yield of presumptive action. So let us now return to our patient from the beginning. At presentation, the plasmic score was high, blood was drawn for Adams 13 given. Treatment was started presumptively with corticosteroids followed by plasma exchange. Caplacizumab, it is expensive and not available in India. And importantly, we did not wait 3 days for the laboratory confirmation. By the time the Adams 13 result returned, the patient had already improved with resolution of confusion and recovery of the platelet count. The lesson from this case is powerful. The laboratory result confirmed what the clinical picture had already told us, but early treatment prevented the consequences of waiting. So finally, future directions. Where is the field going? Recombinant Adams 13. One important development is recombinant Adams 13. The concept is very attractive. Instead of relying entirely on plasma to replace the deficient enzyme, we may be able to directly administer purified recombinant Adams 13. This is already relevant in congenital TTP and clinical development is progressing toward immune TTP as well. The broader concept is precision replacement therapy, identifying the missing molecular component and replace it directly. So this represents an important potential evolution in the management of TTP. Thank you. So to conclude, thrombotic microangiopathy, it is a syndrome in which recognition must be rapid, diagnosis must be structured, and treatment must be timely. When we see thrombocytopenia with microangiopathic hemolytic anemia, we should think of TMA. When TTP is strongly suspected, we should calculate the plasmic score, send Adams 13 urgently, and not allow the laboratory turnaround time to delay appropriate treatment. Because in TTP, the difference between acting today and waiting for tomorrow can be the difference between recovery and irreversible organ injury. Every minute counts, early recognition saves lives. The disease does not wait for the Adams 13 report. Send the test but don't wait for the test to treat a high probability TTP. Every minute counts because early recognition can prevent irreversible organ damage and save lives. Thank you.